So our immune system is there to protect us from invading pathogens. It can clear pathogens that live outside cells. Some pathogens make toxins. It can clear toxins as well. And some pathogens go inside cells, and our immune system is able to kill those as well, including virally infected cells. It also plays a role in finding and killing malignant cells to prevent cancer. And we know that because some immunodeficiencies have a higher incidence of cancer. But also the immune system can cause disease. It can cause allergic or autoimmune disease. We can sort of divide our immune system in many different ways. One of them is the earliest type of immunity, which is the innate immune system, and that involves things like the skin and mucous membrane, which serve as a barrier to infection. We have cilia, which are small hairs lining the respiratory epithelium. They move move mucus, which sort of holds on to some pathogens and then clears them from the respiratory tract. Phagocytic cells, they're white cells that can ingest organisms. They include monocytes, macrophages, neutrophils. Now also they have on their surface ways to recognize a pathogen, because how would our cells be able to tell that there's a bacteria or a virus or so? And so the innate immune system has receptors that look at molecular patterns on bacteria, viruses, fungi. It can't tell necessarily one bacteria from the other, but it can tell a class of bacteria or a class of fungi or viruses. And those are very important. This is the first signal of danger, that there's something foreign potentially causing an infection. And it's necessary for the immune system to start an inflammatory process and then turn on the rest of the immune system, which we refer to as the adaptive immune system. Components of this innate immune system also involve serum proteins like the complement proteins. They have their name because they help antibody kill bacteria, but on their own they can help kill bacteria themselves. They can help phagocytes take up bacteria. There are other proteins in the blood that play a role, and the phagocytic cells themselves can take up and kill organisms. Now, the adaptive immune system is the one you hear more about, and this provides very specific immunity, and there is a specific recognition of a particular pathogen, bacteria, virus, or so. Because we want to be able to recognize very many different pathogens, we don't have too many cells for each one, but we need many to fight off an infection. So the cells that are needed will divide and multiply, and so there's a delay when the adaptive immune system needs to work for about 5 to 7 days. And in that period, the innate immune system is very important, at least in controlling the infection. But once that immune response has happened, there's a memory response. So the next time we see this pathogen, we can respond very quickly, or our immune system can respond very quickly. And the two components of the adaptive immune system are antibodies that are made by B cells, and they're able to clear pathogens outside cells and their toxins, and then the T cells, which do almost everything else. They help the phagocytic cells kill intracellular pathogens. They kill virally infected cells as well as malignant cells, and they also help the B cells make antibodies. So schematically, if you look at the immune system in a very simplified way, okay. So we have phagocytic cells that can take up bacteria. We have monocytes are also phagocytic cells, and they can kill cells inside them, but they require help from T cells. T cells will also kill virally infected cells, and they help B cells make antibody. Antibody and complement can kill bacteria, but together or individually, they can also help phagocytic cells take up bacteria. So all these are tied together to provide immunity. So primary immune deficiency diseases result from single gene defects. They affect one or more of these components of the immune response, and as a result, there's a higher susceptibility to infection, sometimes malignancy, and sometimes autoimmunity. When did we recognize that there are primary immune deficiency diseases? And this didn't really happen until there were antibiotics. Before that, it wasn't too unusual to die from an infection. And then after antibiotics were introduced, people recognized that some people were getting too many infections or would not survive them, whereas others did. And the first description came in around 1950 by Bruton, who described X-linked agammaglobulinemia. Why do we get infection? If we have an immune deficiency of either the innate or adaptive immune system, we have a susceptibility to infection, but we have to be exposed to an infection for that to happen. And so some patients may have immune deficiency and not recognize it, somehow by luck not get exposed to infection. But there are some opportunistic infections that are there either on the host, in the host themselves, but normally don't cause infection. You might find some in water or other places in the environment. Any break in the skin mucous membrane barrier can cause infection, and then if there's an inability to drain the respiratory tract, thick mucus and cystic fibrosis, or if the cilia don't work, or if you have allergic disease that prevents clearance, all this can set you up for recurrent infection. So not everybody with recurrent infection has an immune deficiency. Now, the first immune deficiency recognized was agammaglobulinemia in the 1950, and about 10 years later, hyper-IgM syndrome was recognized, the X-linked form at that time, by two different people, Dr. Rosen in Boston in the United States and Dr. Burton in Switzerland. And they noted that these patients had recurrent upper and lower respiratory tract infection. And unlike other or X-linked agammaglobulinemia, they also had a susceptibility to opportunistic infection, which we only think of as T-cell defect. There's also neutropenia and a susceptibility to cancer. And the disease is characterized by an inability to make any antibody other than IgM or IgD. IgD tends to stay on the cell surface, so there's not much in the blood. And the name hyper is probably a little bit wrong because many patients have normal IgM levels, but clearly have very low or undetectable IgG, definitely IgE, and many patients IgA. There are some patients who have IgA levels, and sometimes even in the normal range, and we're still not sure why that happens. If you immunize patients with hyper IgM, they can make specific antibody, but it's only of the IgM type, and there's no memory response. So after every immunization, it's a primary response every time. There's no memory response at all. And then back in the 90s, 5 groups identified the cause of X-linked hyper IgM as a defect in the CD40 ligand gene. So why does it matter to make antibodies other than IgM? And there are different types of antibodies that provide different function for the antibody. Each B cell will make an antibody of particular specificity. That doesn't change, but when it switches from IgM to IgG or IgA, it's assigning a different function to the antibody. And antibodies can fight infections by binding and destroying microbes or neutralizing their toxins. So schematically, very schematic description of an antibody molecule is it's made up of 2 identical heavy chains and 2 identical light chains. And where the light chain and heavy chain come together at the top here is the antigen binding site. This is the variable region, and this happens or is made by the cell randomly. And the constant region of the heavy chain determines the type of the antibody, whether it's IgM, IgD, IgG, or IgA, and this is what determines the function of the antibody. So antibodies can neutralize viruses, they can clear extracellular pathogens and their toxins, they can clear also intracellular viruses with a high affinity intracellular receptor for IgG, and so this is only an IgG function. They can help phagocytes take up pathogens with or without complement. They can lyse microbes by complement activation. And then they can target cells so that natural killer cells can then kill those cells in a process called antibody-dependent cellular cytotoxicity. And here's where the different functions of, it's not a very clear slide, but what's important to see is that different types of antibody have different functions. If you look at some of the big functions, IgA goes across epithelium and protects the mucosal membranes. IgG crosses the placenta and protects the baby in the first 6 months of life. And IgG, being a smaller molecule than IgM, can go outside the blood and can go outside the vascular system and try and kill infections there. IgE sensitizes mast cells. This is important for fighting parasites, but now certainly in developed world is what causes allergic disease. So a B cell, like other cells in the blood, start from stem cells in the bone marrow and moves along the B cell pathway as it rearranges first the heavy chain, the variable region of the heavy chain. And there it's made up of 3 different gene segments, V, D, and J. And this is what gives the variability in the antibody repertoire, if you like, because randomly a V is put together with a D and a J, and you have this variable region. And there are also other processes that take place that changes the sequence of the coding sequence, leading to changes in what the protein looks like. The light chain has a variable region that's made up of 2 gene segments, and once all this happens, it becomes a B cell, and first has IgM on its surface, then it can have IgD on its surface. That's still an immature B cell, and the B cell does this all on its own until this point. But then when a B cell wants to switch from IgM to IgG, IgA, or IgE, it needs a signal from T cells, which is delivered by CD40 ligand. And then a B cell also either becomes a memory B cell. This is also dependent on T cell and CD40 ligand, or an immunoglobulin secreting plasma cell. This is not as dependent on T cells. So in antibody deficiency diseases, we have a lack of antibodies, and therefore we have susceptibility to infections that cannot be killed off by phagocytes on their own. And the reason we don't have antibodies could be because we have no B cells. That's the A-gamma globulinemia that Bruton described. Or there's a lack of T cell help to the B cell. That's more like hyper IgM syndrome. Of course, there could be B cells, and the B cells don't work as in other forms of hyper IgM and maybe common variable immune deficiency and so on. The types of infections that patients are susceptible to are these encapsulated bacteria, Streptococcus pneumoniae, pneumococcus, Haemophilus influenza, Moraxella, meningococcus. There's also susceptibility to mycoplasma, uroplasma, and many viruses. This is for all antibody deficiencies. And schematically, I'm just quickly show you when the T cell interacts with the B cell. At first, CD40 ligand is not on the cell surface, but once the T cell gets activated, it expresses CD40 ligand. And so you don't find it on a T cell unless you activate it. So when you want to check if somebody has a defect in CD40 ligand, you have to activate their cells. And if you look at this normal individual here, the dotted graph is unstimulated cells, and when you stimulate them, CD40 ligand shows up. And here we're looking at another activation marker, CD25, and that grows up as well. In patients with X-linked hyper IgM, there is no upregulation of CD40 ligand, but they upregulate other markers nicely. And this is sort of one of the quick ways to identify X-linked hyper IgM patients. Now, the T cell helps the B cell to undergo isotype switching. This happens in place in the lymph nodes and spleen called germinal centers. And if you look at a normal lymph node, you find many germinal centers. But because this interaction doesn't take place too well in hyper IgM, if you take a lymph node from hyper IgM patient, there really are no lymph nodes, no germinal centers in the lymph nodes. What kind of complications do patients have? The majority will have pneumonia, and a little over half, or about 40% of the total patient group have an opportunistic infection with pneumocystis. There are a lot of upper respiratory tract infections, and then about 40% of the patients, 60 or so percent of the patients have neutropenia, but 40% are chronic, the rest are intermittent. There's anemia, diarrhea is a big complication, some oral ulcers, and then less and less of sepsis, hepatitis, sclerosing cholangitis, infections of the nervous system, and tumors. Again, luckily they're low, but they're much higher than the general population for those tumors. I put together in this table 2 tables from the surveys that were done around the 2000 or so, one in Europe, one in the US. So putting them together is about 135 patients. And these are the causes of death in those patients. 21 out of the 135 had died at the time of that survey. Infection is probably the largest component. Liver failure is next, and cancer. And this is a one-time, it's not over time, so it's just when the surveys were done. So why do we have susceptibility to recurrent infections and to cancer and so on? And we're not clear that we know that too well. Certainly for infection, the lack of IgG and IgA antibodies and the lack of memory plays a big role there. Opportunistic infections, it's not clear that antibody is enough or the reason for that, because patients will still get them if they are given IVIG. It could be the lack of T-cell help from monocytes, or the fact that the T-cells don't prime well because they're not getting signals back from the B cells or other antigen-presenting cells. And we still really are not sure about some of the other complications and what the pathogenesis is. Now, the majority of patients are X-linked because it's on the X chromosome. Boys only need to have one affected chromosome and they will have the disease. But there are other forms that are autosomal recessive, but then you have to have both copies of your gene have to be affected. And that's what's found out because the same sort of phenotype that you see in X-linked hyper-IgM was found in girls as well. And it's really a defect in the CD40 ligand, CD40 signaling process that would lead to the same phenotype. So here, schematically, I'm going to show you the different gene defects that can cause hyper-IgM. So any antigen-presenting cell, and in this case a B cell, will present a piece of the protein from an infectious organism to a T cell via an MHC molecule. These are the tissue typing proteins, if you like. And the T cells, unlike antibody, the T cell receptor doesn't see the protein as a whole structure. It only sees a piece of the protein presented via these molecules. This activates the T cell, and the T cell will express CD40 ligand on the surface. CD40 ligand then binds CD40 on the, I'm going to call this now an antigen-presenting cell, or the B cell, if you like. And that does a few things. One, it upregulates co-stimulatory molecules that give a co-stimulatory signal to T cells. It's an important signal for the T cell to get. Cytokines also help in T cell differentiation. And in B cells, CD40 will upregulate activation-induced cytidine deaminase and uracil N-glycosylase. These are 2 enzymes that play an important role in this S-type switching from IgM, IgD to the other immunoglobulins, IgG, IgA, or IgE, and also a process called somatic hypermutation. Once a B cell makes an antibody, the antibody clearly was responding to the infection, but somatic hypermutation generates mutations in this antibody, and our lymph nodes, when this is happening, will select out the antibodies that bind even more strongly to the infection. And so we can fine-tune our antibody response to make it much more efficient. And both these enzymes are important for the isotype switching and the somatic hypermutation. Now, X-linked hyper-IgM happens if you have a defect in CD40 ligand. Clearly, if you have a defect in CD40, you're going to get the same phenotype. Both affect not only the isotype switching, but this co-stimulation back to the T cell. And CD40 is not on the X chromosome, so it's an autosomal recessive. Most of these patients have been found in countries where there's intermarriage within the same family. These defects in either of these genes will affect somatic hypermutation, and they're found only in B cells, not in the other antigen-presenting cells. So these patients, actually, the T cells get the signals back. And the difference between the 2 groups of patients is that CD40 ligand, CD40 defects are susceptible to opportunistic infections, and they have small lymph nodes with no germinal centers, whereas these patients actually have big lymph nodes, and because the interaction is happening, but it's not making or it's not switching, and it's not doing that. So the lymph nodes get big. In fact, some of these patients, you have to take out their tonsils and adenoids because they get sleep apnea. And they don't get opportunistic infections. They may have a higher incidence of autoimmunity as well. Any questions on this one? I think everyone here is X-linked hyper IgM, but in the past there have been some patients who have AID defects in the audience. So I just went over that as well. So how do we treat X-linked hyper IgM? Right now, the biggest thing is the absence of antibodies, so immunoglobulin replacement is the first thing to be done. You can do this IV every 3 to 4 weeks, or subcutaneously. We used to say every week. Some of those, you can double the dose and do it every 2 weeks. For older people, there's a product that you can give every 4 weeks. If they have sick, you have to treat them with antibiotics, but we also use preventative antibiotics to prevent opportunistic infections like pneumocystis. You have to be careful about the water supply, not to get cryptosporidium. And then the patients who have neutropenia, you might need to use GCSF. And stem cell transplantation is an option. And what some have raised as questions, if we start early with IVIG, can we prevent these complications? I don't know if we have an answer to this, but it seems like despite IVIG, some of the complications do happen. The difference between IVIG and sub-Q immunoglobulin replacement is that with IVIG you get a high peak, and then you go down to a trough, and we want to keep that trough. Now we're aiming for over 800. Whereas with sub-Q, there's a slower absorption of the immunoglobulin, and so you have a much more steady state. And even if you match the dose, you end up having a higher level than the trough, but obviously you will never reach the peak. And as a result, the side effects are slightly different. Here you are more likely to get headache and systemic side effects, and here it's more local with swelling and irritation. Immunoglobulin is quite safe. In the early 90s, mid-90s, there was transmission of hepatitis C, but now there have been no viral transmission since then. HIV was never transmitted, luckily, because of the way it's prepared. And all plasma donors have to go through physical examination. They have to provide identification. And any donation is kept on hold till the donor comes back. If the donor doesn't come back, the donor is considered unreliable, and the first donation is thrown away. And every donation waits for this donor to come back another time. I mentioned those, and our goal for treatment is to prevent infection, reduce severity and frequency, and allow as much of a normal lifestyle. However, with X-linked hyper IgM, we may need to go farther, and I think stem cell transplantation is an option, and I'm going to leave that to Dr. Della Morena to talk about. Gene therapy is not an option yet, unfortunately, partly because the cells that are deficient CD40 ligand don't have a survival problem. They're made, and so gene therapy would have to be very, very efficient to be able to have enough cells that express the normal CD40 ligand. The other issue is the gene has to be regulated, so that has to be maintained, because if you just express CD40 ligand all the time, you run into trouble with lymphoproliferation and potentially cancer and so on. So this is farther away than some of the other immunodeficiencies.